How do you evaluate and diagnose a postoperative fever? What questions do you ask in the history? What do you look for in the physical exam? What tests do you get? We're going to cover all this and more today at Citizen Surgeon. Welcome back to Citizen Surgeon. This is where you come to be confident on your tests, on the ward, in the ICU, and in the operating room. And today we're talking about fever. My name's Dr. Eric Pearson. I'm a pediatric surgeon, and I'm totally pumped that you're here. For the first two videos, we talked about what a fever is. We talked about set point. We talked about prostaglandin E2. In the second video, we talked about the differential diagnosis of a postoperative fever, timing in the different days, early, late, delayed postoperative fever. So if you haven't checked out those videos, go ahead, check them out, because they are prerequisites to what we're going to learn today, and that's the evaluation and treatment and a better understanding of that differential diagnosis. So when we're going to evaluate a fever, we need to first understand that the differential diagnosis is a range of things. It's a range from emergent, alarming, life-threatening problems to less immediate things. Remember, in that second video, when we talked about the timing of fever, we talked about immediate postoperative, early, late, and delayed. So if you haven't watched that video, definitely check it out so you can have a really good understanding of these phases of postoperative fever. And to reiterate that point, there's this great study by Garibaldi et al., 81 patients they looked at, and they wanted to tie fever with infection. And when they looked at this, they found that on postoperative day 1, 80% of people that had fever had no evidence of infection. While on postoperative day 5, 90% of people with a fever had an infection. So early on, it's most likely due to inflammation rather than an infectious cause. But later on, it's most likely due to an infection. And so you have to be able to suss that out. In this graph, I'm going to take you through each of the different common postoperative infections that cause fever and when they occur, and you can kind of see what the pace is or the tempo of each of these infections. So first we look at pneumonia. You can see that this peaks in the early phase on postoperative day 2, and then it starts to wean off. Next is surgical site infection, and while we talked about early surgical site infection being a life-threatening diagnosis, it's relatively rare. And SSI, as we see that as a wound infection, they increase slowly, peaking between days 6 and 10, and then starting to wean off. We then can see venous thromboembolism, or VTE, has a lower incidence, and this peaks later in that first week, as well as urinary tract infection, deep space or organ space infections, and myocardial infarction. Again, this graph is taken from a paper that I'll post in the references by Hyder et al., where they looked at the incidence of infections related to postoperative fever in a number of patients. And you can see when we put this line on postoperative day 3 that divides our early versus late infections, we can see in that early phase, not many infectious causes with the exception of pneumonia peaking on day 2. Most of the infections are going to happen in that later phase, post-op days 4 to 30. So let's move on to the history and all those questions that are really important to ask. Now, one of the things I taught you at the end of the last video is the 9 W's. And we bring these out because this really helps guide your ability to make that differential diagnosis. And so I know you probably learned the 5, but it's important to know the 9, kind of some rarer cause of infection here, but review these and think about them as we get into these questions. So what are some of the questions that you need to ask your patient? Some easy questions that go along with those 9 W's are, do you have any pain? Is that incisional pain, or do you have pain in your lower extremities? Think about a venous thromboembolism or that walk W. All right, do you have a cough with sputum production? Are there any urinary symptoms? So these are some of the questions that I want you to think about asking when you have that patient with a postoperative fever. Another line of questioning that you need to think about is not only asking those subjective questions, but think about the patient's journey. Did the patient have a fever prior to an operation? For example, were you operating on perforated diverticulitis and you had fecal peritonitis and the patient was septic and they had a fever before? Well, now that's going to lead you to intra-abdominal abscess or maybe an anastomotic leak or peritoneal contamination as that cause of ongoing fever. And then we get into the history. So does the patient have any contacts with fever? In this era of COVID, we have to think, like, do our patients have COVID? Do they have family members with COVID? Have they had any recent travel? Are they taking any new drugs? I gave you that table of all of the different drugs that can cause fever, both antibiotics and non-antibiotics. Do they have a history of postoperative fever? So think about malignant hyperthermia as a life-threatening cause of fever. Do they have any history of that? Especially if this is in that immediate postoperative period, those hours following an operation. And then, of course, we want to review the operation itself. What was the timing of the operation? How many days ago? So thinking about those phases. Was it an emergency operation? Was there sepsis present before the operation? Did we do an anastomosis? Were there any complications? Did we make enterotomies that we had to repair? Was it a complicated lysis of adhesions that took hours? And of course, it's important to review the anesthesia record. Think about transfusions or other drugs that the patient could have received. And of course, we want to review immune-related causes of fever. So definitely review the patient's chart for any allergies, medications they've received, or any transfusions or blood products they may have received. Now this leads us to our physical examination. In the physical examination, I talked about a lot in my video on the acute abdomen. So if you haven't seen that video, get back to it. That's going to introduce not only my history questions for an acute abdomen, so SRN, OPD, SARA. If you don't know those 10 questions, watch the video, find out. And also my method for observing or getting a general impression of the patient. And so that's Chandler, or color, hydration, alertness, nutrition, disability, limbs, external support, and respiratory distress. So does the patient have any of those things on observation? So that's the first thing. So first, take a general look at the patient. Is this patient sick or not sick? How are they breathing? Are they in distress? What are their vital signs? Are they lethargic and responsive? One of the things we find in elderly patients who have an anastomotic leak is one of the first findings are mental status changes. So take a careful observation of your patient, and that's going to give you an idea of what you're looking for as far as a cause of this fever. Second is you want to make a systems-based evaluation of the patient. Now the reason you want to go systems-based is so you do it the same way every time. So you want to look at the neurological system. You want to look at the respiratory, the cardiac system, the hematologic system, the GI system, the genitourinary system, and of course the endocrine system. And if you do a careful physical examination through each of these systems, you're going to have a lot of data that you can fall back on to find out the cause of this fever. The third thing I want you to think about is you got to look at the wound. We're a surgeon. We make wounds. Wounds get infected. So is there pain? Is there erythema? Is there drainage? Is there fluctuance? Is there warmth? I did 2 good videos, one on surgical site infection, another one on wound classification. There's a third one on wound healing. So if you haven't seen those, check those out. Those are going to give you a good understanding of wound healing and then again, surgical site infections and how that relates to how we classify wounds, whether it was a clean case, clean, contaminated, or dirty. And finally, it's important to think about stuff. We do stuff to patients. We put in tubes, we put in lines, we put in urinary catheters, we put in central venous catheters. So these can be a source of infection, and it's important to think about what devices or what implants does a patient have that could be a leading source of infection. And finally here we're going to get to tests. All right, so what tests do you need to order? And do you even need to order any tests? So if there are 3 things that I want you to take away, it's number 1, do not blindly order a whole panel of tests because you have a fever. Make sure you do your history and physical exam first. Next is let that history and physical exam guide you to the tests that you want to order. And third, always ask this question: will the data change your management? All right, will the data change your management? If you have redness and fluctuance and pain and erythema of a wound on postoperative day 6, and you know it requires drainage, is a CBC going to help you change your management? No, you're going to drain the wound. All right, so think about that as you begin to make decisions on treating a postoperative fever. What data do you need? And so to drive that point home a little harder, I'm going to tell you that a routine diagnostic workup is not indicated in the immediate and early phases if the patient is hemodynamically stable and doing well. Let the patient's physiology guide the tests and the workup. Now, I'm not saying that all tests are not indicated. I'm just saying that immediate and early phase. And so there are tests that you want to consider that are going to help you make a diagnosis. So labs, a CBC or complete blood count with differential, a CRP or C-reactive protein, a comprehensive metabolic panel with liver function test or liver blood test. This can give you a lot of data on how the patient is doing across all systems. And it can also give you data to support a systemic inflammatory response syndrome. Remember that the white blood cell count is a part of the criteria for SIRS. Other things you want to consider are looking at each of these systems. So do we need to get blood cultures? Would a urinalysis with culture be helpful, knowing the diagnostic criteria of UTI? Would a sputum culture be helpful if the patient has a new productive cough, dyspnea, and a new oxygen requirement? This could also lead you to get a chest x-ray. Do you need to get an ultrasound, perhaps of the abdomen looking for an abscess or fluid collection, or of the lower extremities looking for a veno thromboembolus? And then finally, do you need other imaging, a cross-sectional imaging, perhaps looking for an anastomotic leak or an intra-abdominal abscess? These are just some tests to consider. There are others, for example, thyroid function tests if you think perhaps thyrotoxicosis. But this will get you started looking at those patients after you've taken a thorough history and physical exam. Now, one thing I want to throw out there that may be a little controversial, but I'm going to give you some data for it, is that atelectasis does not cause fever. All right. Now, here are a handful of papers. I'll put links to these in the references. But I think that atelectasis and fever are really true unrelated. Do patients get fever in that early postoperative period? Yes, they do. Do patients also get atelectasis in that early postoperative period? They're not taking deep breaths, their abdomen hurts, they're having some lung collapse? Yes, they do. Does atelectasis cause fever? I think this is surgical dogma, and I would say that the evidence doesn't support a causal relationship between atelectasis and fever, and here are some papers that'll get you there to understand it. So now that we've gone through our history, our physical exam, we've ordered some tests. So what are some alarming causes of postoperative fever? Read into this, what are life-threatening causes of postoperative fever? So because we're surgeons, we're learning about surgery, the first one I want to be on the top of your mind for alarming or life-threatening causes of fever are necrotizing soft tissue infections. We talked about in the last video as early surgical site infections. And so what do you look for? The first thing is dishwater drainage. From the wound, you'll typically get this gray, murky looking fluid draining from the wound. You also want to look for erythema, edema, induration, bulla can form or blisters can form around the wound, and you can also get crepitus. One of the features that is also almost pathognomonic for this is if you have pain in the wound that's out of proportion to what you'd expect. So if somebody has these findings, dishwater fluid, edema, erythema that's spreading, and they have pain that is not what you'd expect, you really have to be thinking about necrotizing soft tissue infections. And I'm also going to put a link in the description to some tools that you can put in your arsenal for scoring on whether you should be worried about a soft tissue infection or not, based on kind of clinical as well as some laboratory findings. Remember that while these necrotizing soft tissue infections can be caused by a range of bacteria, there are two major ones. That's group A strep as well as Clostridium perfringens. So those are the two major players. If you do need to get imaging to help aid in the diagnosis, the major finding will be edema on those cross-sectional images, but you can also get gas. Now, if you have gas in the soft tissues, and you're worried about a necrotizing soft tissue infection, the sensitivity, specificity, and positive predictive value are here, and you can see that if you have gas on your imaging, that's highly specific with a positive predictive value that you have a necrotizing soft tissue infection. So how do you treat this? We treat with resuscitation, surgical debridement, and antibiotics. The resuscitation and antibiotics need to be started immediately, and those antibiotics include broad spectrum coverage. Vancomycin would be a choice, combined with Zosyn as well as clindamycin. Clindamycin helps absorb up those streptococcal toxins, and so that's why that's added. We also want immediate surgical debridement, and that needs to be done within 24 hours of diagnosis. And I would say that that is way too long at 24 hours, that as soon as the diagnosis is made, that you need to be on your way or in the operating room. So next on our tour of alarming or life-threatening causes of fever is pulmonary embolus. So patients with pulmonary embolus can have a fever, and it's usually a low-grade fever. And in a large study by Murray and colleagues, they found that 14% of patients with pulmonary embolism had an isolated fever. So this is important to consider in that differential diagnosis of postoperative fever. Next is anastomotic leak or abscess. Remember that 9th W was what did we do to the patient? If we did an anastomosis, there's a chance that anastomosis is going to leak or fall apart. And so if that happens, you're going to get an abscess, leak, and obviously peritoneal contamination with sepsis. So that's an important cause. And the treatment for that, surgery or IR to either repair the leak or drain the abscess, as well as fluid and antibiotic coverage. Number 4, and these are not in any order of importance, but just to be aware about, is alcohol withdrawal. So often we get patients that have alcohol addiction and alcoholism, and when they withdraw from alcohol, they can get very, very sick, requiring critical care. So we want to use tools like the CYAR, and that's to help score and to identify alcohol withdrawal. And then critical care with benzodiazepines or sedation to help manage these patients is critical in their care. Number 5 is adrenal insufficiency. So in those patients that perhaps were on steroids before, they have a big operation, and now they're having a Addisonian crisis or adrenal insufficiency postoperative, it's important that these patients are identified. Questions are asked. Could they have adrenal insufficiency? Do they have risk factors for this? These patients need their ABCs evaluated, airway, breathing, circulation. They also need replacement of those adrenal hormones. So they need glucocorticoids and mineralocorticoids like hydrocortisone and fludrocortisone. And finally, a 6th cause of an alarming cause of fever would be malignant hyperthermia. We talked about this in the last 2 videos, but this is an inherited condition of those defective ryanodine receptors. So you get massive calcium release, which causes skeletal muscle contraction and a ton of heat production. This leads to code thermal and protocolized treatment, usually with dantrolene, other medications, and procedures to help bring that temperature down. And so those were our alarming causes of fever, but those are not always the most common. The most common causes of fever we're going to talk about right here, and those are the important ones. We talked about them in the beginning of the video, usually occurring in that late phase between days 4 and 30. And let's talk about them right here. So first is UTI. That's the most common hospital-acquired infection. So if you have a patient that had a genitourinary procedure or they have a urinary catheter in place, you want to be thinking, could they have a catheter-associated UTI? Another thing you want to ask yourself every day is, if my patient has a Foley catheter, can I pull it out? Why is that Foley catheter in place? If you're rounding on your patients, you got to ask yourself that every single day. Number 2 is pneumonia. So this we saw peaked on postoperative day 2. This is an important cause of hospital-acquired infection. A reason that we want to make sure our patients are walking on postoperative day 0, that they're using their incentive spirometer. I like patients to use this 10 times every hour. I tell them, if you're watching TV, do your incentive spirometer 10 times during all of the commercials, but make sure they're walking, getting up, expanding their lungs, dropping those diaphragms. We can have a catheter-associated bloodstream infection. So if you have a patient that has a central venous catheter, maybe this was a temporary central venous catheter, or they have an implanted catheter, they have a Broviac line if it's a little baby, could this be the cause of the fever and infection? Infected prosthetics are important to think about. So patients that have had mesh placed, patients that are orthopedic patients, perhaps they've had a hip or knee replacement or another orthopedic device placed. Important to kind of consider those as a cause of fever, a cause of sepsis and infection in the postoperative phase. And then finally, Clostridium difficile. So patients that have antibiotics are going to have a disruption of their microbiome. You're going to knock out all those good healthy bacteria, and Clostridium difficile can overpopulate. Now, I've seen fulminant colitis with patients getting incredibly sick, requiring total colectomy for C. diff infections. But usually this presents with abdominal pain, diarrhea, sometimes hematochezia or blood in the stools, and it needs to be tested for and treated, usually with Flagyl, either IV and oral, or oral vancomycin. Okay, so today we've talked about Okay, so today we've reviewed the 9 W's. We talked about the history of the exam, tests. We talked about alarming or life-threatening causes of postoperative fever. Then, of course, we talked about the common causes of postoperative fever. So let's summarize this all up. So first is the differential diagnosis of postoperative fever should be considered a range of problems, from the alarming or life-threatening to the more common causes. Inflammatory or non-infectious causes of fever are common in the early phase. And so a routine diagnostic workup with a ton of labs and imaging is not necessarily indicated, but you do need to do a thorough history and physical exam on every patient with a fever. Remember the 9 W's as a guide to your differential diagnosis? Your history should focus on patient details and the patient's journey or clinical pathway of why they may be having a fever. Tests need to be guided by patient data, and think of the immediate life-threatening causes and the common causes when you have a postoperative fever. I hope you've enjoyed that talk today. These 3 videos on fever. The number 1 video we talked about was what is fever? Why do you get a fever? We talked about set point. In the second video, we talked about the timing of fever, that immediate, early, late, and of course the delayed periods. And in this video, we talked about how to take that history physical exam, how to work up a fever, how to develop that differential diagnosis. If you like this video, join the community, go ahead and subscribe. Sign up for the email list. I'll email when a video is coming out. You can also sign up for my Saturday 6 or the 6 things that I'm pumped about each week, both in the operating room, in the hospital, and then how I manage to have a balanced life and stay engaged as a husband, a father, and then in the hobbies I enjoy, like getting out on my mountain bike. And also, I love to engage with you, so leave a comment. What did you like most about this video? What would you like to see next time? Share it with your friends, and as always, be safe, study hard, and I'll see you next time.